Assalamu alaikum, hello and good afternoon. You are listening to Atiyah on the Mental Health and Emotional Wellbeing Show on Ramadan Radio Wolverhampton and online on ramadanradiowolves.com. You can also find us on Facebook and other social media like Insta. In the show today, we hope to provide information that may be helpful to support your well-being and the well-being of others, because everyone's mental health matters. You can listen back to this and previous shows on Ramadan Radio Wolf's YouTube channel, alongside finding further mental health information on my X feed at Atiyah Ali3. We are not here to offer you advice in place of your clinician. However, we will share information that may encourage you to seek support. If you feel you need to discuss your health and well-being following this show, then please contact your GP or mental health professional. You're very welcome to send comments regarding the show via the WhatsApp messaging number on 07440 420 432. Our guest today is Dr. Saadia Muzaffar. She is a consultant adult psychiatrist, having trained in Exeter and gaining her consultancy from the Royal College of Psychiatrists, UK, in 2013. She is experienced in using many modalities of psychotherapy and went on to further train in cognitive analytic therapy. She also co-chairs as Associate Registrar Wellbeing at the Royal College of Psychiatrists in UK. Okay. As a examiner at the Royal College of Psychiatrists UK, she is an IMG champion for Hampshire and the Isle of Wight Trust, and also set up Medical Advisory Committee and chairs this. Her research doctorate is looking at the well-being of South Asian women, and her current interests remain in transcultural psychiatry with the well-being of South Asian women, especially doctors, and the mental health of women. And Saadia and Dr. Muzaffar is here to tell us more about this. Welcome to the show, Saadia.
Thank you, Atiyah, for having me.
And thank you for joining us. Could you firstly please share the role of a psychiatrist?
Yes, no, of course. So I often get asked what's the difference between a psychologist and a psychiatrist. So essentially, a psychiatrist is a doctor. They've completed their 5 or 6 years of medical training, and after that, they gain experience after postgraduate membership exams and deliver prescribing, assessing, diagnosis of mental health disorders. Mm-hmm. So there are some who also go on to train in psychotherapy, like I did, just to understand what the holistic needs of an individual are. But basically, a psychiatrist is someone who assesses, diagnoses, and treats common or complex mental health disorders.
Mm-hmm. And I'm sure you'll go on to share examples of those as we talk. It's really warming to hear about of a psychiatrist who has further studied in psychotherapy. So you've kind of opened your mind to other ways of treating patients alongside the medicinal way, is what I'm hearing you say. What interested you in focusing on women's mental health in particular and transcultural psychiatry?
It was mainly my sort of clinical experience, and also I think anecdotally, informally, having lots of South Asian women contacting me for a friend or a cousin or a family member, and then not really wanting to go to their GP or to a counsellor or officially to a psychiatrist. And some of these are actually practicing doctors, and that sort of made me sit up and think, if they're actually treating other patients, what are they really doing for their own mental health? If they can't really go to a GP for fear of stigma. And this is the sort of educated lot, as you would imagine. and yet the cultural stigma and shame is such still around mental health in our South Asian communities, which then started this sort of journey of looking at research around this area.
And you've said there that those people that might be aware of mental health services were actually quite reluctant in seeking support. Is that what I'm hearing you say?
Yes, it is. And it's different factors. And I think in order for us to tackle that cultural stigma and that shame, and those sort of some negative attitudes or myths that we might have to dispel, but I think that's going to take a cultural shift of right from policymakers up in even in medical schools, early training, how we embed that into the medical students' lives of being a reflective practitioner. And I think challenging mental health stigma through the communities, just working really closely with them. And we've done that here in Hampshire, where we've worked with imams, we've worked with the chaplains. So we've worked with the local communities and their religious leaders, or somebody they respect within their community, because they're more likely to receive advice and information and be signposted by them than they are if you'd ask them straight to make an appointment with their GP or go to a psychiatrist. And often I've heard from people in South Asian communities saying, and these are educated people, it's not your sort of stereotype that people think that they are living in poverty or they don't have the resources available to them. There's a lot of educated people who will say to me, I'm not mad, I'm not going to a psychiatrist. so I think it's a cultural change and shift that's needed, and it's coming. I think the next generations are still a bit more clued up with what mental health is about, especially common mental health disorders like depression and anxiety, and even deliberate self-harm, the cutting and eating disorders in this community as well.
Right. There's a few things that you touched upon there that's I'm interested in particular. Medicine, you talked about doctors and training and encouraging them to be a bit more reflective. What do you mean by that? Do you mean talking about mental health or being reflective in themselves as individuals and seeking support?
So essentially, I think all educational institutions, or especially like in medical schools now, they have wellbeing advisors. I think it's about creating the awareness around being more mindful, living in the present. Life is stressful, whether they are early career doctors or medical students or any other professions. I think it's important, but because we're talking particularly about doctors, I just want to add here that I think there's a sense of an imposter syndrome that's been recognized across the world for medical students as well as doctors. And what that essentially means is that it's sort of characterized by self-doubt, not opening up and feeling like a fraud, and hence not asking for help when they actually need it. So it's about, I think, first of all, identifying simple symptoms of depression and anxiety in themselves or their friends or people they're working with in their environment. And I think that's the first step. But equally, I think establishing some formal support networks, including peer supervision, one-to-one support, that could help them overcome any kind of work-related stress that they've encountered. They have exam stresses. So at least in the medical schools, they're beginning to embed that culture through the policies and the curriculum, and emphasizing the work-life balance, which is huge. So that's going to prevent burnout in the long term. And burnout is becoming a huge issue in the medical community. And unfortunately, there have been suicides in the South Asian community, and a few of them recently have been male GPs. Some have been female GPs, which is a real worry for the medical community, because these are highly skilled, highly educated individuals, and it makes you wonder what drives them to the point of suicide, where they are actually using violent methods of suicide, which are sure to end their lives, and also about help-seeking behaviour. There's a sense that in doctors you can't ask for help. You're supposed to be resilient. You're trained and taught to be leaders, and there's a sense that you can't ask for help. Otherwise, there'd be implications on your professional repute, for instance, or you'd be seen as incapable or incompetent in some ways, which is again part of that stigma that needs to be addressed, and that help-seeking behaviour needs to be encouraged more.
Doctors in particular, are they aware of working their way around the system, let's say? So for some people, they might say, well, if we go on to work at the surgery, they'll be aware of my medical history, etc. Do these kind of conversations come up when people think about accessing mental health?
So I think it's they're less likely to go. That's where the problem lies. Many people are less likely to go through formal routes, and therefore they will call a friend of a friend who's a GP, or if a psychiatric assessment's needed, they'll informally talk to them. Some of them are more likely to talk to family and friends rather than go down the formal route. I think there's a real fear, and especially in international medical graduates, who by definition are those doctors who've achieved their primary medical qualification outside of the UK. And as you know, the NHS is, since the 1950s, 60s, the NHS has been supported by the international medical graduates, and by 2030, it's expected that they will form more than 55% of the workforce across the UK in the NHS. So it's really pertinent to support them, because I think there's a sense that many of them have left their families back in their country of origin, whether that's India, Pakistan, Sri Lanka, Bangladesh, and they've made a life here. So there's a lot at stake. And then there's exam pressures as well. So I think they just, many of them just put their head down, focus on the exams. I have known and supported international medical graduates over the last few years, and I'm fully aware there are some who've had to sell their land, or families had to sell a piece of land for them to get the flight here. So it's as if they've burnt all their bridges of returning back. And then the pressures, obviously, as you know, then are huge for them to secure a job and to be able to work and qualify in this country.
You've shared there the importance and the necessity of this field, in particular this area of work where you're focusing on working with South Asian doctors. 55% is a phenomenal amount of doctors that will be working in the field, and you've shared some of the complexity around their journey to the UK and embarking on work. I'm thinking a little bit about what the differences might be with those doctors. So the difference from those who are emigrating to the UK and those who work here, born, bred.
So there's for the former, the international medical graduates who've emigrated from another country. There are obviously the support systems aren't locally. They're not as efficient for them. They miss family events. There's obviously homesickness. There's the concept of acculturation. Many of them don't take to the weather, or they don't understand the structure of NHS. And there's, like I said, there's a lot of pressure from them, from their families back home as well, for them to do really well. So if anything were to happen here, they wouldn't be able to tell them for fear of failure, really, which puts a huge amount of stress on them, and sometimes due to a lack of understanding of the system in which they work, the NHS, they are bound to have difficulties in communication with their teams, come across as aloof or preoccupied. We had somebody who was from an occupied territory, a doctor, and their supervisors were talking about how they come across as quite indifferent almost to the rest of the team. But when you actually sat down and spoke to them, they hadn't heard from their parents for the last 3 weeks. They hadn't had that regular phone call where they would touch base, and that was a bit like their lifeline, as it is for many of us, connection with family and friends. And so it's things that are happening back in their country, political crises, that's going to impact their mental well-being. And he couldn't have his young newborn son and his wife over as soon as he had expected to. So it's a raft of everyday things that many people who are local doctors will probably take for granted, having your mum and dad down the road or in the next city, drivable distance. Or if they're elderly and they've not, they haven't got somebody to look after them in their country of origin, and those frequent trips and the stress. So there's a whole raft of things that they have to sort of deal with. But with the right supports, and I think now across the country in NHS, most of the trusts, there are IMG champions who will look after their well-being, and try and sort of buddy them up with a mentor who's from their country of origin, who can sort of make them feel a bit more comfortable and more welcome. However, I would say that the international nursing graduates have a lot more support than the international medical graduates, and I think we probably need to learn a bit more about how they support them as compared to the IMGs.
So the IMGs that's not the international medical, is that what you...
Yes, those are the, yeah.
Okay, so they offer some support, and whether that support is accessed and whether it needs more clarity in terms of access, is that right?
Yes, and I think a bit more, probably I think those support systems need to be more enhanced in terms of induction of the doctors. Right. And there is an enhanced IMG induction program that's being rolled across the country, which I think is going to make a huge difference.
Okay. Now, with regards to the understanding of mental health, are you finding that there's differences between those who emigrate here to work and those who are already settled in the UK? Is there a difference of their understanding of mental health problems, or is it just stigma-based that people don't access? I know no two individuals will be the same, but what themes have you noted?
So far, there doesn't seem to be a huge amount of difference in the mental health, towards mental health, the attitudes, if you're asking about the first generation or the second generation. However, there is evidence that usually by the third generation, the acculturation bits have settled, and they're more likely to be able to ask for help or at least identify it. However, I will say that even if you're looking at, let's say, a second generation Pakistani, Indian young individual, whether they're doctors or any other profession or working or not, I think it's going to boil down to how their family views mental illnesses, just because we often get patients who will be ready for treatment, but then you will lose them halfway through the treatment because somehow the family's taken ownership, which is a wonderful thing. However, sometimes people would benefit more from having a bit of both, having the mental health being treated, but also family support. But sometimes they have to be, so they're sort of maybe put in a position by their families where they have to make a choice. I have heard from some female patients when I've asked them what their sort of fears are when I'm prescribing antidepressants, and they've said, well, my mum said, or my cousin said, or my aunt said, you're not going to get married if you're on antidepressants. And in our community, the news travels fast, and that's going to ruin my chances of a good marital proposal. As you know, there are still a lot of arranged marriages that happen in our communities. So there's it's more embedded in the culture, and how their family views mental health is also quite important, because it really does influence some of our young individuals.
Yeah. And this family kind of views, it can be quite dangerous for some people, can't it?
So where I'd say the risks are huge if we don't do anything about this now, in terms of educating our communities, and especially women, whether it's elderly women in the households or they're young, educated, working women. I think if we're not careful, we're already aware that postnatal depression after the delivery of a baby, a woman is quite likely to develop depression if she's already had pre-existing depression. And let's say if that was of a degree that was untreated, sometimes it has progressed to postnatal psychosis. What that really means is that the mother will hear voices instructing her to kill herself, but also kill her child. And we do see that as psychiatrists in our everyday practice. There's postnatal psychosis, there's postnatal depression. And if that's not treated, you're talking about the lives of the whole family being impacted upon. So I think the key is to sort of have some education around what the signs and symptoms are of postnatal depression, and when it progresses towards postnatal psychosis.
You shared there the importance of being aware of signs and symptoms and issues that might arise, and accessing support as early as possible. But there's a fine balance between understanding you have a problem and then seeking support. I wonder what stops individuals from seeking support. And you mentioned a few examples of why people might not access mental health services, but we will go on to talk a bit about that after the break, if that's okay. And then also I'm interested in your research, I believe around South Asian women in particular, is that right?
Yes.
Yeah. So we'll pick up from what you've shared there after the break. I think it's really important to share the identification of symptoms, especially for anxiety and depression. As you said, they're probably the primary experiences of individuals. Is that correct?
Yes. There's a 1 in 3 people will experience anxiety and depression at some point in their lives, and that's just 1 in 3 anywhere, any community, at some point. And life is stressful. So how people respond to it's going to vary in different settings, different life phases. So yes, I'm happy to talk about that.
The statistics. We'll pick this up on the other side of the break.
Thank you.
Welcome back. You're listening to the Mental Health and Emotional Wellbeing Show with Atiyah and our guest, Dr. Saadia Muzaffar. Before the break, Doctor, you were talking about women who were, doctors, South Asian doctors in particular, and working in their field of medicine, and how it can become very stressful for individuals, and that there's a stigma attached sometimes to accessing services. You also mentioned that people should be aware quite early on in terms of their symptoms of depression and anxiety. I'm wondering if you could elaborate on that a little bit.
So I think depression and anxiety generally, like I said, it's very common, and whether it's our South Asian community or we're talking about the doctors, anyone, nobody is sort of immune from it. So in terms of recognizing depression, let's say if you noticed a friend or a family member going through any of these, the first point of contact would be your GP. And the psychological symptoms of depression usually can be quite subtle. It might just start off with somebody becoming a little bit more withdrawn. They've taken to their room. They're not coming out, not going out with you. They've stopped enjoying some of the activities that they used to enjoy. They have lost appetite, and they appear sort of flat in their mood, not as talkative, maybe talking more about guilt, tearful episodes, and that their sort of self-esteem takes a beating, or they've lost interest in things, or even simple things like not being able to make decisions. Feeling quite anxious, and that there's this loop of thought, of ruminations that keeps going in their head. And physical symptoms, they might feel a bit more physically slowed down. They may gain weight. Sometimes they may lose weight as well, and a lack of energy. But I think specifically for our South Asian community, you will often hear depression. There is no word for depression in the language Urdu either, which is quite telling. And how women and sometimes elderly men will also communicate their psychological pain, as it were, is in terms of physical symptoms such as unexplained body aches and pains, lack of energy, or they'll talk about they've got pain in their joints. Or that they're getting old and tired, or they find it difficult to sleep. So it's all of those, or it could be a combination of some of those. And it's, I think, primarily the impact it has on an individual's life. If you see that it's impacting on their well-being, their academics, maybe if they're a student, on their social life, or let's say if it's a young mum who's just had a baby, who is not, and I think that's why it sometimes gets masked, because it's a busy time of the life of a mother, young mother, and you think you've got to appear cheerful and happy because you're blessed with a beautiful baby, but I think hence depression gets masked because they appear, just to everybody else, they just might appear tired. But people who know them really well will know that something's off, and it's a bit more than just a low mood. In terms of the symptoms for anxiety, again, the things to watch out for would be physical symptoms. Those are quite common, where they will complain of palpitations, the heart racing, headaches. A lot of women complain of frequent headaches, which have like a band-like sensation around their head, or they might feel quite restless, or pacing, sweating, sleep difficulties, or feeling nauseous, or having panic attacks, and that they're avoiding crowds or public places, or they've had to leave a public situation or a crowd just because they've had a panic attack, and they've had some breathing difficulties where their breathing suddenly become quite shallow. So I think those are the things to watch out for. Those are the common things that you might see in people around you. But then on the mind, there's that sense of living with that sense of impending doom, that something terrible is around the corner, or they can't stop worrying, or they're constantly, their minds getting these ruminations as sort of like a vicious loop which feeds itself, that something terrible will happen, or people aren't happy with them, or rethinking a situation again and again. That's a very common one and easy to spot. Or they might feel quite disconnected from people or the world around them. Yes, so, or from their parts of their body as well.
Yeah.
So, yes.
Extensive list there, actually. Thank you, Dr. Muzaffar, for those changes in behaviour that you've explained, and the physical symptoms, alongside the physical symptoms. I'm wondering if we could spend some time looking at and thinking about your research. You've shared that your research is focused around South Asian women, and also doctors. Could you tell us a little bit about how you came about to doing your research, and what helped you focus on this area? I mean, I know you mentioned something around this at the beginning, but if you'd like to emphasize what helped you think about this.
I think it came about through, I'd say, clinically working in the field of psychiatry, seeing a lot of women suffer to the point where they reach either suicide or, like I said, postnatal psychosis, and just the extreme state of neglect that I've seen them in when I've gone to see them at home, or there have been colleagues or friends whose family member has contacted me, and I've had to talk to their GP and alert them about a crisis that's coming up, because I think things get left too late, and there's a certain degree of denial around it. But also, I think that at the heart of it is the cultural lack of sometimes cultural sensitivity that people or maybe their parents have experienced through services, a bit of stigma. They're afraid sometimes and ill-informed about antidepressants as well, that they will cause side effects, and then they will create a dependency. Sometimes people aren't really clear about the role of counselors or therapists. I think that's still improving, but I still feel that women and men in the older generations from this community would still probably look at it with a bit of skepticism, and they prefer, and with which, to be honest, there's nothing wrong with it, but they would prefer to talk to their friends and family and see them as their main person to go to and ventilate. But then often many people will also go to faith healers. Faith and religion is a huge part of our communities, and it's also protective in lots of ways. But sometimes I think there's a sense that if somebody's going through psychosis, I have heard that people will say he's possessed by jinn, and if we go to they'll go for an exorcism from a spiritual leader before they'll go to a psychiatrist. So it's more acceptable in some families to go down that route and have this sort of supernatural cause. The sort of attribution to the cause of illness will be supernatural rather than actually being mental illness. It's worse in terms of the stigma. And I think there's also the sense that it's inappropriate to talk about your personal problems. Let's say if somebody's going through depression due to their relationship problems between a husband and wife, let's say, for instance, or if their child is struggling, they can't go to the doctor and talk about it. Or even neurodiversity is still not talked about in our society and in our communities. It's seen as sort of as if you can't really. It's a personal problem rather than a mental illness of depression or anxiety, or neurodiversity being accepted as a strength of people. So I think there's a huge amount of resistance culturally. And also there's frequent, I mean, we're fortunate in the UK, we have Professor Bugran Bui did a literature review on expression of sort of mental distress of Indian subcontinent origin patients to their GPs. And they found that there were frequent presentations to the GP for somatic symptoms like medical problems or pain in the chest or pain in the joints, but they would never talk about any psychological distress or ever psychiatric disorders. So the explanations of illness model is quite prevalent and attributable to superstition, supernatural, and medical causes.
Mm-hmm. So some of what you mentioned there, is that from your research that you've come about? I know you've mentioned.
So that's through the literature search that I've done, but also my main body of work is around South Asian female doctors, only because being one myself, having treated informally, sort of talked through and supported informally some female medic colleagues, and also in my clinical practice as well, some doctors, and having treated them to the point where I saw them where they were at the point of violent methods of thinking of suicide and left suicide notes. So that's sort of the main area of interest. And through that work, just very briefly, I found that female doctors have been known to have much more depression than male doctors. And this is across the board. This is not just South Asians, but South Asian female doctors are known to have a lot more depression than men. Female doctors generally also experience more anxiety, and they don't seek help for these issues either. And I think the difficulty is there's not enough research around this. And what we suppose is that there's a cultural role conflict. Many of them can't work until they have a supportive husband or supportive in-laws, because it's a family unit, and it's and many of them will say, we get home, we'll get in the kitchen, start cooking, prepare meals, and it's like you've got to be everything for everybody all the time. And I think some of them feel that they get quite worn out. Then there's the pressure of exams as well at a young age, where you're raising young children and you've got the pressure of exams to pass to progress your career. Then the impact of night shifts on family life. And I think there's also something else that we're coming up against, is that they often lack suitable female role models or appropriate mentoring, which can actually hinder their career advancement. If you see South Asian male medics, they'll be, and many of them are very supportive towards South Asian female counterparts, which is amazing and wonderful to see. However, at times in the past, that's not always been the case, and that then hinders their sort of career opportunities, academia, positions in academia, especially for women, of generally ethnic minorities. If we look at statistics, there's very few female academics across the board in a lot of specialties. But again, if you look at ethnic minorities, they're a minority in their own right. And obviously, suicide is a big concern. It's a huge concern in doctors in South Asia, with rates being recorded as higher than the general population. I'm aware that in India, it's estimated that doctors generally have 2.5 times higher suicide risk compared to the general population. And the use of violent methods like hanging and self-poisoning is quite common. in just to mention that in the UK we have a charity called Doctors in Distress, which was started by Amandeep Sidhu, who's the brother of a cardiologist who sadly took his life. And he's really championing the cause of doctors who are experiencing difficulties and depression and in isolation, and what is it that stops them from seeking help. And I think work then becomes a strategy for burying your sort of pain in a way that numbs your pain, so you continue working. And in fact, some people, some medics then overcompensate by working excessively. So people around them wouldn't ever think of them being depressed. And that's a dangerous place to be, I think, for these really highly qualified, really competent and compassionate individuals, where they are looking after other people day in, day out, nurturing them. But they can't extend that to their own individual identity, as if they're sort of almost cut off from that identity, and that's their only purpose. But if you're if you have a healthy medical workforce, you've got better patient care. There's implications on safety of patients as well, and I think generally majority of the doctors are really good at not putting anyone else at risk. But what ends up happening is, because of their conscientious nature and their training, the way they had their medical training, they will actually neglect themselves rather than anyone else ever. So, and I'm not saying that that doesn't always happen. I mean, I think sometimes the risk is that if they're under that much pressure and working in isolation, there could be errors made as well. So that's why I think those sort of regular support systems need to be in place, and reflective practice sessions for doctors, because they're more likely to talk to their peers than to go anywhere else to seek help.
And where do these reflective spaces come about? I mean, do you find it's common within services?
So there are certain groups called the Barlant groups, which were started by a GP in the 1980s in London, at Guy's and St Thomas, and he started them, and they've now caught on across different trusts and across different medical staff in the country. But it just basically provides a space for the doctors to talk about how a certain difficult, and they deal with very complex, challenging situations, cases, which will challenge them, I think, mentally as well as emotionally sometimes. And that's a good space for people to sort of become aware of their own blind spots, as it were, and to bounce off thoughts on how a patient's situation made them feel, and how to look after themselves and be aware of their own bias, because sometimes we bring any doctor, the best qualified that they are, but if they're not self-aware, they can bring a certain degree of bias. It might be an over-identification kind of bias, where you're over-identifying with a certain patient that looks like you or has a similar story to you. So you've got to be aware of all those things. And that's where these...
I do wonder actually how many trusts hold these reflective groups. I don't know whether it's as common as it should be.
It's difficult to say how many, but I'm aware that many trusts are implementing these, and I think there's something around policies and workforce that would create a culture, and I think it's these little things that will create a culture that challenges the stigma and encourages help-seeking behaviour, and I think minimizing blame. Because if a doctor is aware that it's going to have huge implications on their career, or they're not safe to practice, that's their worst fear, and they'll continue working. But then they need to ask for help, early on.
Sure. Can you share some of the success stories where doctors have sought support and been able to feel better?
Usually, when the trainees are going through their training, through their deaneries are usually responsible for their well-being. So are their supervisors and the trusts that employ them. But generally, there's a professional support unit at the deanery. If there's any difficulties, their supervisors will signpost them, or they will have regular Balin groups. But equally, I think there's just want to highlight Practitioner Health, which was it's a confidential, it's free NHS primary care, mental health and addiction service, and they have expertise in treating healthcare professionals. So that's also a huge resource for doctors. That was started by Dr. Claire Gerardo, who is a GP in London, and they've been, I think, quite crucial. This is the feedback I get from a lot of people who have been treated by that service, that it's enabled them to get help at the right time, or it might be through their GPs that they've, usually it's a peer, it's a supervisor who has sort of highlighted some concerns or worries, or checking in on how they really are. And I think just treating them more as a human being and what's their personal life like. So not just a sort of tick box exercise of how they're doing academically with their exams or on calls, but also having a discussion about what's happening at home for them. Are they coping fine, and what coping strategies have they got, and then being able to signpost them. So I think those have really been quite useful and helpful in getting help. And I have seen some junior doctors, when they've got the right help within the first 6 months and it's been identified, they have flourished and they have thrived in their careers later on as well.
And what you have stressed there is the importance of seeking support as soon as possible. Dr. Saadia Muzaffar, if people wanted to get in touch with you, how could they contact you?
Please do email me. I will leave my email address and my LinkedIn profile as well. But
okay, so you're available on LinkedIn as well.
Yes, thank you.
Perfect. Thank you very much for joining us today. It's a shame we didn't get to speak a little bit about cognitive analytical therapy, and how that supports you as a psychiatrist in your work in engaging clients, individuals and their families. So looking at mental health from a different perspective. Thank you for your time. Thank you everyone for listening in today. Please stay tuned. We have another lovely guest coming in next week, Saturday at 1:00. So you'll hear from me next Saturday at 1:00. Stay tuned.
Thank you.
Assalamu alaikum.